Dr. Priyanka Singh is an assistant professor in AB WIMS in Dr. Arman Hospital, and her area of interest is pediatric anesthesia and chronic pain management. Welcome, Dr. Priyanka.
I am Dr. Priyanka, assistant professor in the Department of Anesthesia and ABV IMS, Dr. Arman Hospital. Today, I will be discussing a newer class of oral anticoagulants, that is direct vector TENI inhibitors. As a postgraduate student, you all can come across with the patients that are already on one of these drugs presented in PAC for an elective surgery and for emergency surgeries in OR. Also, this can come as a short note in your postgraduate exam. So let's just quickly have a look at the coagulation cascade that we are all aware of. As the name suggests, these drugs directly inhibit the vector TENI, which further prevents the formation of thrombin from the prothrombin, and which further prevents the clot formation from fibrin. The conventional oral anticoagulants, that is vitamin K inhibitor warfarin, has some limitations like delayed onset of variable dose responses, narrow therapeutic window, more drug and drug food interactions, inconvenient and frequent monitoring, and high chances of bleeding. These limitations arise the need of an ideal oral anticoagulant that has an antithrombotic effect without bleeding, predictable dose response, no need for the monitoring is required, reduced need for dose adjustments, no food interaction, and limited drug interactions. So, the new or novel oral anticoagulants came into picture first in 2010. This term came out with the development of the first agent, that is vinelrestan. Further, in 2015, based on their action, that is direct oral anticoagulant, EOAC term has been prescribed. Then ACCP CHEST guidelines further use the term NOAC, that is non-vitamin K oral anticoagulant. That has been widely used nowadays. Other terminology is target specific oral anticoagulant. These NOACs include two classes of drugs, that is direct thrombin inhibitor and direct factor TENI inhibitors. So there are 4 oral factor TENI inhibitors available at present, that is rivaroxaban, that is Xarelto, apixaban, also known as Eliquis, edoxaban, Cyazypyr, and betrixaban, that is Tarexan. These are the years in which they are approved by FDA respectively. All of them have the advantage of rapid onset and offset of action, short half-life, wide therapeutic window, so is convenient to use, fewer drug and drug food interactions. They have predictable pharmacokinetics and pharmacodynamics. Routine laboratory monitoring is not required, and nowadays we have antidotes available for them. But they come with certain limitations that in use, that is patients with clinically significant active bleeding, patients with coexisting hepatic diseases, and hypersensitivity to these drugs. Concomitant use of other coagulants and antiplatelet agents and NSAIDs can increase the risk of bleeding. Prior to the initiation of all the NOACs, assessment of renal function is important because agents like rivaroxaban and apixaban are not recommended in patients with creatinine clearance less than 15 ml per minute. Edoxaban is contraindicated in patients with creatinine clearance of more than 95 ml per minute. The disadvantages are that these agents are not approved for use in pregnancy and children less than 18 years. They cannot be used in patients with mechanical heart valve, malignant diseases. Cost is an important issue as they are expensive and their antidotes are also expensive. Since these agents are new, there is limited experience with these drugs, and the non-availability of antidotes in remote area is also a problem. Now, currently, there are 4 FDA-approved indications. The most common is to reduce the risk of stroke and systemic embolism in the patients with non-valvular atrial fibrillation. It is also used in treatment of DVT and pulmonary embolism, in prophylaxis of DVT and pulmonary embolism, and in prophylaxis of DVT in patients post hip and knee surgery replacement surgery. The fourth and the newest agent, that is Betrixaben, has only one FDA-approved indication, that is venous thromboembolism prophylaxis in acutely medically ill patient, which is hospitalized for an acute medical illness who are at risk for developing thromboembolic complication due to moderate or severe restricted mobility. Now, other off-label indications are prevention of thromboembolism after PCI with non-valvular atrial fibrillation, for which rivaroxaban and apixaban are in use. Prevention of thromboembolism after percutaneous coronary intervention with peripheral arterial disease, for which edoxaban is in use. And prevention and treatment of cancer-associated deep vein thrombosis. Now, if we compare the FDA-approved indication, both rivaroxaban and apixaban have three common indications, that is used in non-valvular atrial fibrillation, prophylaxis and treatment of DVT and pulmonary embolism, and DVT prophylaxis for patients of knee and hip replacement. And Betrixaban, that has only one indication that we have already discussed, that is VT prophylaxis in acutely medically ill patients. Now, what are the dosing regimen? It mainly depends on the renal clearance of the patient. Rivaroxaban is used with the dose of 20 mg OD with food if the creatinine clearance of the patient is more than 50 ml per minute, and it reduces to 15 mg OD if the creatinine clearance of patient is in between 15 to 50 ml per minute. Less than 15 ml per minute, rivaroxaban is not recommended. The most commonly used indication is DVT prophylaxis, and rivaroxaban is used in the dose of 10 mg once a day. Apixaban is used in the non-valvular atrial fibrillation patients in the dose of 5 mg BD. And if the age of the patient is more than 80 years, body weight is less than 60, and the serum creat of the patient is more than 1.5, the dose is to be reduced to 2.5 mg BD. Apixaban for DVT prophylaxis is used in 2.5 mg twice a day. This is commonly used in this current situation of COVID-19 for DVT prophylaxis. Edoxaban is used in the dose of 60 mg once a day or 30 mg once a day, depends on the creatinine clearance of the patient. Betrixaban, which has only one FDA-approved indication at present, used with the first dose of 160 mg followed by 80 mg once a day. Now, comparing the pharmacokinetics and pharmacodynamics of these drugs, the bioavailability of rivaroxaban is maximum, so it is rapidly absorbable, and it has the least Tmax. The protein rivaroxaban has highest protein binding, that means it is a non-dilutable agent. Food affects the absorption of rivaroxaban as well as betrixaban. Hence, these drugs are to be taken with food at the same time of the day. The metabolism of rivaroxaban and apixaban is mainly in the liver by the enzyme CYP3A4, and the renal clearance is by the enzyme P-glycoprotein. The metabolism by CYP3A4 is minimally seen in edoxaban and betrixaban. The elimination half-life is lowest for rivaroxaban and it is highest for the betrixaban. All the direct vector 10A inhibitors comes with a black box warning of high chances of bleeding and thrombotic events with the premature discontinuation without adequate continuous anticoagulation. The various drug interactions are seen when using these drugs with the CYP3A4 and P-glycoprotein inhibitors and inducer with anticoagulant, and if it is used with NSAID aspirin platelet aggregates inhibitor in rivaroxaban and apixaban. And as we know that the edoxaban betrixaban metabolism is not affected by CYP3A4 and CYP3A4, so only P-glycoprotein inhibitors and inducers cause drug interaction with these drugs. Now, further discussion will be based on this case-based scenario of a 72-year-old female with non-valvular atrial fibrillation. She has been taking warfarin for stroke prevention. Her history includes hypertension. So, what is her CHADS-VAS score? What is CHADS-VAS score? It is an ACC-AHA recommends these score for assessing the risk of stroke in patients with non-valvular atrial fibrillation. It has various factors in which scores has been given, and the total score is counted at the end. So, if the indication for starting of an anticoagulation therapy with NOAC in non-valvular heart failure fibrillation has been sought out, the risk of assessment of stroke as per CHA2DS score has been to be calculated. If it is 0, the NOAC is not required. If it is 1, NOAC can be considered. And if it is more than 2 or equal to 2, it is indicated. Now, when the indications of anticoagulant has been met, we next have to look for whether the patient has trouble in paying for his NOAC. If the cost is not an issue, then we have to look for the creatinine clearance of the patient. If whether the patient has mechanical heart valve or moderate to severe hepatic impairment or any significant drug-drug interaction. If answer to all these questions is a no, then you can go with the initiation of direct factor Xa inhibitor therapy. Now, how does we switch from warfarin to suppose rivaroxaban? As we know that patient was on warfarin, and now we have to switch to a direct factor Xa inhibitor. So comes the role of oral anticoagulant switching. Now, from warfarin to DOSA, as we see, you have to discontinue the warfarin, and if you wish to start rivaroxaban, then INR should be below 3. And if you wish to begin apixaban, then INR should be below 2. If you want to switch from a low molecular weight heparin to NOAC, then stop the old medication and start the new medication when the next dose is due. And same goes with the one drug of direct factor Xa inhibitor class to another drug. You have to stop first drug and then start the second drug when the next dose is due. If the dose is missed, the risk of bleeding is high. Now, the same patient have a situation where she needs a GI endoscopy. So, how will you manage your direct factor Xa inhibitor doses? The American College of Cardiology states that interruption of a NOAC for low, intermediate, high bleeding risk procedure should occur for a duration based on estimated creatinine clearance rate. As we can see, all these agents should be at least discontinued for 24 hours, and then based on the creatinine clearance of the patient, they can be discontinued for 42 hours to 96 hours prior to the procedure. Now, when can we give the next dose of the direct factor Xa inhibitor post the procedure? That depends on the bleeding risk of the procedure. If the procedure was a low bleed risk procedure, then you can give the next dose of the drug 24 hours post procedure. And if the procedure was a high bleed risk, you have to give the drug at least after 48 to 74 hours of the procedure. Routinely, the coagulation is not to be monitored, is not required to be monitored in these agents as the drug dose response is predictable. But if at all, in some situation, the monitoring of the coagulation is required, we can go for an anti-10A activity and prothrombin time, which shows a linear dose response. Now, the same case with AF taking rivaroxaban presented to your trauma center after a road traffic accident. She has polytrauma to the chest, abdomen, and pelvis. Chest tube drainage is right. That means patient is actively bleeding right. So, what comes next? Nowadays, we have an antidote for direct factor Xa inhibitors. That is andexanet alpha, which is a recombinant factor Xa molecule that is catalytically inactive but binds factor Xa inhibitor and facilitates the reversal of both direct and indirect factor Xa inhibitors. Now we have to first look for the last dose of direct factor Xa inhibitor that has been given to the patient. If that dose is less than 7, if that dose has been given for less than 7 hours from the episode of eating, then you have to give bolus of 800 mg followed by an infusion of 8 mg per minute of this agent. And if the last dose of direct factor Xa is being given more than 7 hours from the bleeding episode, you can give a bolus of 400 mg followed by an infusion of 4 mg per minute. The efficacy of this antidote can be measured by change in anti-factor Xa activity and clinical hemostatic efficacy after 12 hours. Other non-specific adjunctive therapies that can be used in the situation of major bleeding are fresh frozen plasma Prothrombin complex concentrate that comes in a 3-factor prothrombin complex concentrate and 4-factor prothrombin complex concentrate that include factor 2, 7, 9 and 10 in the dose of 50 units per kg. Antifibrinolytic agent can also be used. Oral activated charcoal can also be used. Patient can go for hemodialysis. And nowadays we have a universal antidote for all the class of the anticoagulants, that is 80%. Then a few words about the role of oral factor Xa inhibitor in COVID-19 infection. Direct factor Xa inhibitors have been reported to promote potential therapeutic benefits in the coronavirus infection. Apart from their anticoagulant activity, they are reported to have an antiviral activity by inhibiting viral anti and protein processing, and an anti-inflammatory activity by reducing the cytokine and production and inflammation. Another article published the effect of dexamethasone on direct factor Xa plasma level in patients with COVID-19, which says that dexamethasone being an inducer of both CYP3A4 and P-glycoprotein potentially reduces the bioavailability and increases the clearance, leading to decreased plasma level of NOAC. So these agents are generally not recommended in patients on dexamethasone, and low molecular weight heparin is recommended, though for now it lacks the evidence. So to conclude my presentation, we have some take-home points. That is, all these NOACs have become viable alternatives with non-inferior or equivalent anticoagulation to conventional warfarin. Common errors related to NOAC use includes prescribing to inappropriate patients, recommending an inappropriate dose or administration, and inappropriate monitoring. Rapidly evolving knowledge related to NOAC use highlights the importance of improving awareness of these new agents and incorporate best practice standards into clinical. By this, I will end my presentation. Thank you so much.
There is one question that twin pregnancy is considered as which ASA? So, if it is an uncomplicated, I would keep it as ASA grade 2. And Dr. Anshu, I don't know whether she's there or not, but then I will keep it as ASA grade 2 in case there is no complication. And in case complications are there, then Dr. Anshu has given beautiful charts. So depending upon whether the complication, like it's mild or it is severe, we can make it as ASA grade 3 or ASA grade 4, etc. So no other questions we have. So, okay. So we, do we have any other questions? I could not see any more.
No, ma'am.
Okay. So we thank Dr. Anshu, and she has done the ASA grading beautifully. And she has told all the details. Then Dr. Nitin and Dr. Priyanka for their beautiful talks about anticoagulation. And we thank the organizers also. Thank you so much.